start.
I have to say hi to my friend Alia. Hi, Alia, it's Lisa.
Hi, Lisa.
How are you?
I'm good. How are you?
I'm good. I can't wait to hear your session.
Oh, well, I hope to live up to your expectations.
I'm certain you will exceed them.
Okay.
So no pressure.
All right, sounds good.
And you know, I always agree with everything you say, so it won't make any difference, right?
Sounds good. Sounds good.
All right, I think we're going to get started. So welcome everyone to the set of breakout sessions here on day 2. To make sure that you are in the correct space, this is a presentation from New Hampshire about population health and a hotspotting project. So I'm just going to help get us oriented to the room here. A reminder that all sessions are recorded, so you'll be able to check out the other breakout sessions that are happening concurrently at this time, so you won't necessarily miss any of that content. If you have any technical difficulties, please utilize the chat feature and I can assist you with that, or our support from CVent. We really encourage your questions and interactions during this session with the presenter. For questions during this session, you can type a question using the chat, or you can certainly verbally ask a question too. If you want to verbally ask a question, if you could use the raise hand icon, that's probably best. So you can access that icon underneath the participants at the bottom center of your screen. If you click on that, then you can see a raise hand icon there, and then we'll be able to notice that and call on you to ask your question. You can then do that by unmuting your microphone, but we do ask that when you're not speaking that you keep your microphone muted so that we reduce any unneeded background noise. So with that, I'm going to turn things over to Caleb Syme with the National Rural Health Resource Center to give a proper introduction to this session.
Hey guys, thanks Tracy. So I will introduce Alia and let her introduce our learning objectives, which are in her presentation. Alia Hayes began her role as the Rural Health Manager for the State Office of Rural Health in New Hampshire in May of 2017. She manages the Flex and SHIP grant programs for New Hampshire's 13 critical access hospitals, also the state's only small rural hospitals. Alia will be presenting on a project funded by the Small Rural Hospital Improvement Project grant called the Population Health and Hotspotting Project, or abbreviated PHHP. Thank you, and please join me in welcoming Alia.
Hi everyone, and thank you for joining this session. And I was just talking to Lisa Davis about how I hope it lives up to your expectations. This is about New Hampshire's Population Health and Hotspotting Project, as Caleb said, which is abbreviated throughout some of the slides. And as a statement, this project is supported by the Health Resources and Services Administration of the U.S. Department of Health and Human Services as part of a financial assistance award totaling $166,868 with 100% funded by HRSA and HHS and no additional amount of funding from non-governmental sources, and the content are those of myself and not necessarily represent the official views of or endorsement by HRSA or HHS or the US government. So there we are. So many of the presentations you've heard thus far at the reverse site visit and the ones that you'll hear going forward are really about all the amazing things that have been accomplished by the state flex programs. And as we begin this presentation, I really wanted to state that this project was about learning my limitations during a really challenging time and kind of taking a deep breath when odds were stacked against the project and everyone involved in it. So as you go through the remainder of the reverse site visit, try to take a deep breath and remind yourself that what the keynote speaker said yesterday, which is we are all doing important work, keep going. So our objectives for today are to summarize how the Centers for Disease Control and Prevention, or CDC Places Tool, combined with local data, can be effective in helping hospitals focus on prominent health issues in their service areas, and then identifying how hospitals can align their community benefit dollars and their community health needs assessments and create profiles from that. And then to give an example of difficult project conversations and taking the workload temperature of participants during a pandemic. So the funding acknowledgement that I have is that this was funded by SHIP funds, but it could easily have been funded by flex funds. So that population health focus in flex area 3 is where this would fit in very easily and seamlessly. So even though this was funded by SHIP, it could have been funded by flex. So in terms of the beginnings of this project, years ago, I was actually sitting in the audience of our hospital association meeting when a gentleman by the name of Kevin Barnett from the Center to Advance Community Health and Equity began talking about Z code. So that's the catch logo at the middle. And this was a method of coding for social determinants of health to stratify patients by risk and then figuring out which patients may need additional coordination of services. And I was absolutely fascinated by this idea. And so following that presentation, my workout buddy here at the Division of Public Health Services started talking to me about something called the Community Health Outlooks. And so there's a small picture you'll see, and I'll show you in a moment on the next slide, a little bit more detail. But they created these Community Health Outlooks as part of the CDC grant for our environmental public health tracking program at the Division of Public Health Services. We are in state government. So they had created these communities of 500 people or more in order to analyze communities' social determinants of health and some other data. And this was small numbers, and that was really exciting. So as that same colleague and I continued to work out, and she actually moved over to the Bureau of Public Health Statistics and Informatics. She started showing me how she could layer that data to look at our highest risk communities. So that's kind of that middle map that you see with the browns in it. And when I thought about my work with rural hospitals and recognizing that they are major providers in their rural towns and they have lots of different primary care clinics, et cetera, this really helped me realize that if they could focus their services better, placing which services are the highest need in which areas, it would really help them to improve overall population health and community health. So, especially because we know transportation is the biggest issue across any rural area that you look at. So it was kind of an exciting piece, and I just started to pursue this idea and try to plead my case that this can be done with small numbers. So these are the community health outlooks. Again, these are those clustered 500 or more communities. And then they analyze everything from household income to single parent households to risk for asthma, preventable asthma ED visits, heart attacks, hospitalization rate. You can see all different pieces, and these are much more extensive. This is just a snapshot, but they are on our website at the division. So it was really exciting, and I thought this will help us, so we can do this. So as this project developed, we were able to bring in tons of additional partners. So the Foundation for Healthy Communities is the one who holds the contract for certain parts of this project. We also have our chronic disease section, who's now joined in and provided additional funding starting around September that we're going to improve, hopefully, some chronic disease care and management in rural communities that have high needs. The Bureau of EMS is going to be also in on that same piece, helping to promote mobile integrated healthcare initiatives. The New Hampshire Public Health Tracking Group is still involved in the project and helping to look at some of that data as well. And then the Bureau of Public Health Statistics and Informatics is actually going to have a full-time person eventually within that bureau to help with all this data analysis. So essentially every person or group that we spoke with was really excited and on board. And so we've been gaining momentum in terms of the number of partnerships and collaborations. In addition, we actually, came full circle, and now we have Kevin Barnett, who's been handling the community benefit profiles that I'll discuss a little bit more in depth later. So it's been a pretty exciting snowball to watch in terms of collaborative efforts. So we outlined this process. We thought, okay, phase one, we're gonna identify all of the population health contacts at different hospitals and meet with them and see if they're interested in this. We're gonna get them to complete the population health assessment, which is an IHI tool. And again, I'll show a snapshot of that later. We're gonna gather all this additional data. We're gonna do GIS mapping. We're gonna do these community benefit profiles. It's gonna be awesome. And then in phase two, we'll review all that data with the hospitals. We're gonna identify gaps and opportunities. We're gonna link them with the community health improvement plans and the regional public health networks, which is kind of we don't have smaller health departments, but our regional public health networks are basically as close as it comes. And then phase three, we'll continue this like action plan development and goal setting, and we'll be able to figure out which tactics, which activities. We're gonna work with the hospitals really closely, and we'll bring on TA if we need to, and all of these different exciting things. And we were all energized and ready. And then COVID-19 lockdown happened. So as you all know, what happened over the past year and a half, and it was just a hard stop to all of our activities for the most part. So then it was, what do we do now? And that was when we had to have some really difficult conversations. In terms of our data capacity, it was stopped. All of our current data analysts were partially reassigned to COVID-19 data analytics for the most part. We weren't able to hire anybody because of a hiring freeze at the state. So then we had to go through a waiver process. Then we didn't have any applicants because nobody wanted to work in a big building with lots of people in cubicles. And then there was no interest in a part-time position overall. So in recent times, I've been converting that position to full-time, and that is also a lengthy process at the state. So I'm in the midst of that process now, but I had to keep going back to the hospitals over the past few months and just saying, I'm working on it. I'm trying really hard to do what we need to do to get this project to move forward. But we are having a difficult time with the data analyst person. So then we also had to encounter these difficult conversations with hospitals and what they were going through. So most of their population health staff were reassigned into other roles. They had this priority of, we have to survive. We have to make sure we survive through all of this. And there were just so many different obstacles and challenges that were in front of them. And we just had to say, listen, we understand that there's a different priority now. And what would you like to do at this point? And so it was a lot of those conversations. We're just talking to them and acknowledging that this was difficult for everybody and what hard work they were doing on a day-to-day basis. So it was, for the most part, I want to say some of the most empathetic interactions that I've had over the past 4 years that I've worked for the state. We were all just trying to acknowledge that, yeah, we're all in this together. We're all having a difficult time. We're all handling more than we ever have. And for the most part, most people had some sort of personal challenge going on in addition to their professional challenges. So it was hard, but it was also good to see the good in the people that you work with. So this is that tool that I was talking about with the Institute for Healthcare Improvement, their Pathways to Population Health Compass Assessment. This is one of the pieces that some hospitals have been able to complete over the past year or so. They essentially go through their organization and try to figure out what are in these 4 different brackets, where are their strengths and where do they need to keep working in terms of physical and or mental health, social and or spiritual well-being, community health and well-being, and then communities of solutions. So in terms of that's more connecting with others and community-based organizations. So some of our hospitals have been able to complete those, and some of them have been able to get kind of a report out from those. And then the CDC Places Tool also came out. I'm not sure how many of you have gotten a chance to explore this tool, but I was I couldn't decide if I was excited or kind of devastated at the moment that it came out, because I thought, oh no, there goes all of our data importance from the state. But my data focused colleagues told me this is just a snapshot, and this is not taking all the data analytics out of the hotspotting project. Instead, this will only help. So this tool is great in that it can give you kind of an overview of an area and look to see where are there clusters of some sort of issue, whether it's people with high cholesterol, kidney disease, COPD, or things like, trying to think of the unhealthy behaviors, or how well they've felt over the last 7 days. There's mental health as well as physical health pieces, and it's based on the ACS American Community Surveys, I believe. So it was good to help me since the data person is not on board yet. I've been able to kind of zoom into each hospital service area and say, okay, where might there be a significant difference? And then kind of taking a look at that so that when we do have a data analyst on board, they can look at that more in depth and look at that based on claims data at the state level and or outpatient data. So it is a really helpful tool to kind of get a grand overview. And that's what I've been able to do with it to help out in place of having the statistics person ready to go. And then there's also, we just launched our new DHHS data portal in New Hampshire, and we were able to advocate for and get launched a rural and non-rural button. So people can see the rural areas versus the non-rural areas. Is there a significant difference? And so in this particular thing, we're looking at asthma hospital encounters, and did that vary or was it significantly different between the rural areas of New Hampshire and the non-rural areas of New Hampshire? So that yellow is the rural areas and that blue is the non-rural. So it's been really great. That tool has also been developed by the Bureau of Population Health Statistics and Informatics. And so they were already on board with us trying to get that data a little bit more clear for our stakeholders. And then these are the community benefit profiles. I tried to block out everything that indicated which hospital this is, but it's a super comprehensive report that was done by Kevin Barnett in the Center for Advancing Community Health and Equity. And they have everything from where are they spending their community benefits dollars to what were the community health needs that were identified in their community health needs assessments. And then where are their priorities based on that funding? And then they actually take that information and compare it to this, which is their community health needs assessment. You can see here their implementation strategy. And then actually the regional public health network that I told you was kind of like a regional health department, but not really, and how it aligns. So how does their work align with what else is going on in the region so that they can figure out where is there a mismatch and where could they potentially partner with them. So it's a really hopefully helpful tool and data that they can use moving forward to realign some of where they place those community benefit dollars. So it's not just going into a health fair or sponsoring a run or something like that. And then this is opportunities for alignment. So there was the different public health network priorities that are identified, the community health priorities, and then how they could align with each other again to ultimately help each other and collaborate to improve health as best as possible. So overall, the lessons that I learned through this project thus far, and there will be many more, I'm sure, is the importance of communicating. Early and often, I was trying to make sure that it didn't come as a surprise to anybody that we couldn't hire somebody, that it didn't come as a surprise to anybody that nobody would apply. It didn't come as a surprise to anybody that there was a lack of applicants to a part-time position and that a full-time position may be needed. So it was really important to be able to say to them, this is what's happening, and they were often very receptive. And then also saying to them on their hospital activity side, in terms of the compass assessment, we're here when you're ready. You know, we're not pushing anything, we're not expecting anything out of you at this moment. And when you are ready for this, this is ready for you. So that was a really important acknowledgement of just everything that was happening. So, and then providing what we could. So we're doing the best with the CDC Places data that we can versus the ultimate goal of mapping and overlaying and all the really cool stuff that I want to be doing. So it's what we can do at the moment. And then converting the position to a full-time position because we know it's needed. We know we're way behind in terms of project activities and deliverables. So hoping to catch up. And that's what I have. I'll leave this slide up for another moment in case anybody would like to contact me about what we're doing or what's worked, what's not worked, but that's all I've got. Thank you.
Great, thank you, Alia. Any questions for Alia and her discussion related to population health efforts and data utilization?
Caleb, this is Lisa Davis. I don't mean to jump ahead and take up all the available time. So, but I have a bunch of questions. And so Alia, thank you so much for this. So here are all my questions, and they might be something that somebody else has, or you can choose not to answer half of them. So the question is, when you were looking at population health data, were you also comparing that to the community health needs assessments that the hospitals had done? How were you identifying the population health contacts? And what definition was your person whose name I can't remember using when he was looking at rural and urban?
So I'm going to answer the last question first because that's how my memory works now. And that question, the answer to that question is their definition of rural is based on our definition of rural within the State Office of Rural Health. And so that is really good because we were able to identify our areas based on the map that we already have. So that was awesome. And we've just been able to kind of pull that all the way through all of those mapping, all of the mapping that they are doing through the Statistics and Informatics, Bureau of Population Health Statistics and Informatics. So that was really helpful. The second to last question is, go ahead, say it one more time.
Sorry, I muted myself.
No problem.
How did you identify the population health context?
Okay, so there are several things. One is that Foundation for Healthy Communities is the community benefit group that is associated with the New Hampshire Hospital Association. So they have a lot of different groups that gather. For instance, all of the population health leads are all invited on a monthly basis to meet at the Foundation for Healthy Communities. And they all gather and kind of share great ideas and have presentations, et cetera. So some of those people had self-identified, and then others who hadn't. My line is always open when I communicate with the hospitals. So the CEOs typically point me to the person, or I say, you can either continue getting all of these emails, or you could give me the person who I should be sending this to. And honestly, the CEOs have been incredibly receptive to talking to me, sharing all of their doing even during the pandemic. So they're really good at helping me to identify who that person is. There were a couple of cold call situations where it was like, all right, well, you know, I think this might be the person, let's try this person. And then they may have switched roles or may have left the hospital, but they usually linked us to somebody else. So that was it was a work in progress at the beginning, but then it's really, we have the population health leads identified at most of the hospitals, where the CEO is really the person who wants to be spoken to about everything. You know, everybody leads a little bit differently. So sometimes they want to be in those first meetings anyway, and then they kind of delegate from there. So. And then
I'll just quickly ask my third question, and then I'll stop talking. So in terms of looking at the population health indicators, were you able to overlay those with the community health needs assessments, or did they serve any part of the sort of data collection or validation process?
So the population health data is, the way that they're comparing in the community benefits profiles is so they're looking at what has been identified in the community health improvement plans. So they look at data that we'll also be looking at in those community health improvement plans. And the regional public health networks have data about their areas, which oftentimes align really well with a critical access hospital service area. But we did not overlay that directly because that data person isn't yet here. So the community health outlooks could be put together for a hospital service area, but they're too small level, believe it or not, to kind of look and see differences. In the environmental public health tracking program has also kind of had other priorities in their work plans. So they have started creating high-low tables based on a hospital service area. So they could say, okay, the number of households with a single parent for children under 18, the high region is this part of your service area, and the low region is this part of your service area. So we're kind of at this point working with the data that has been analyzed already, haven't gotten that person on board, but hopefully eventually we're going to overlay those too.
Thank you so much. Great presentation.
No problem.
Great, thank you, Lisa. What other questions do we have for Alia?
I'm gonna stop sharing. I'm happy to see that we have as many, if not more, participants at the end than we did at the beginning. That's always usually a good thing. So
yeah, right.
That's I feel great. Pretty good about that.
Absolutely. You mentioned earlier that it's just beneficial for you to say, hey, like, we're still getting feedback from hospitals. They're still participating. They are interested in this stuff. Just, you know, everybody's busy right now. Were there other, I mean, maybe that wasn't a surprise, especially when in the midst of everything else, what's going on, that hospitals are interested. Are there any surprises that you came across?
There are definitely, it's always interesting to hear when we first present an idea, who is on the extremes. They're typically the same hospitals that are on this side versus this side. So one hospital was like, I don't believe you can analyze the data at levels that small. And I was like, I'll tell you why I think we can. Right. And I'll tell you why I think we can prove you wrong. But I will, you know, the proof is in the pudding, and I love those challenges. I love that the CEOs feel that they can and should challenge me. And then there's the hospitals that are just like, we're way ahead of you. We got this, we're going. And it's so good when we were talking about how to get this going. This was supposed to be the pilot year, and we were supposed to have 2 hospitals, and the 2 hospitals that I wanted were the yes uptakes, and then the people that were like, you can't do that, because you don't always want that ready to take on anything group, because first off, you know that they're doing that with a lot of other things. And then also you want to be able to prove to that naysayer that it can be done and that this is valuable. So I love that they're, you know, they will send me emails or call me up and be like, I want you to know about this thing that we're doing. We just have a really good, also we have the benefit of having only 13 hospitals. So way smaller than many states, but they will call me up and talk to me because there's something going on, or they want to talk about, you know, well, this project, how does that fit in with this other thing? And it's great. It's awesome.
Yeah, absolutely.
Kate, I see how are you actually literally using the SHIP funds? So two things. One is those community benefit profiles and other services from the Foundation for Healthy Communities is a contract. So that is the technical assistance that they're getting from the foundation to enable them to complete the Institute for Healthcare Improvement Compass assessment. And then also on top of that, they're connecting them with any community-based organizations in the end that will be able to help them with their work plans, that, you know, where they decide their priorities should be for their population health efforts. They are also going to be, they are also doing the community benefit profiles. So they're working with Kevin Barnett on that side. They are also doing the several meetings with each hospital to introduce them to the project, to be able to let them know what our plans are, what the phases are, et cetera. So that's a contract. And then we also are now, it was part-time and now moving it to full-time, the person who will be doing the data analysis. And actually we are hopeful that we can continue to support that person to provide critical access hospitals with data, because we know that's where we kind of fall short. So to what extent is the State Office of Rural Health involved in population health? So many ways, and actually more and more each day. So I'm not sure how many of you in this session have received or involved with the distribution of the CDC COVID disparities grant. However, New Hampshire is getting $25 million and we are using 1.42 to go toward critical access hospitals to help, and I started describing this a little bit, but didn't go a ton into it, to start doing mobile integrated healthcare initiatives to help manage and prevent chronic disease progression and illness. And so the chronic disease section is working with us as well as the Bureau of EMS on that initiative. We are also helping with them develop their interfacility transfer. They are hiring personnel to start working on interfacility transfers, which we know affects hospitals, and then that ends up affecting population health overall, because if you can't get services when you need them. And then we also, there's so many, there's a lot of different initiatives I feel like that we're involved in, and I will inevitably forget one or two or many. But we're also, Elisa Druzba, who is my supervisor, but also the administrator for the state office, she is actually starting to work with some of that CDC COVID disparities money on transportation. So there's the regional transportation commissions are actually going to get some money to start developing transportation services to improve population health. So lots of different little and big projects depending on the day and depending on the funding. And I'm sure many of you also feel like there's funding just falling from the sky every second. So, you know, tomorrow I may be able to list off 3 more projects, but yeah, we oftentimes are trying to gather information from hospitals on what are they already doing in the population health space, and we never know all of it. You know, just a few weeks ago, I talked to one of our hospitals, and they've started a prescription food service program, food pantry. So if they have a diabetic, they get a prescription to go to the food pantry and get certain foods that is through food provisions from the New Hampshire Food Bank. So it's it's really amazing all that they are doing. Thank you, Leslie. Yeah.
Other questions do we have? We have 5 minutes until the end of this scheduled breakout session before we go into our next session is a group discussion focused on the transition to value and value related efforts within your state. So it would be great to continue this conversation in our next group discussion where Terry and I will facilitate that. As I said, we have 5 minutes left. Let's keep our questions going for Alia and our conversation as well. Sally.
Alia, this is Sally. Hello.
Hi.
Thanks for presenting on this. This was great, showing integration between SHIP and Flex and SOAR. Can you talk about like moving forward now that kind of you talked about, so there's the CDC funds coming in, but in terms of for this project, maybe that like, and hopefully sites being able to support population health and data of the type of training that you all provide to the CH staff.
So it's really interesting that you say that, because I feel that they are very much in this boat where they know they are so on board for the most part with population health that we haven't gone down the road of what kind of training do you need yet. I think one of the things that we're working on really a lot harder now is that collaboration and network, because, so caveat, I used to be a school teacher. Some of you know this, and what we found was that in the school was like the last standing community organization. And so everything fell on the school and it felt incredibly overwhelming. And I think at this point, that's the rural hospitals. So they feel responsible for everything from food insecurity to education to parenting classes to all of these things. So it's really our work, I think, instead of training, it's really connecting. Who else is doing this work in this area? You know, every few years they do the community health needs assessments. They don't necessarily then connect with a lot of the organizations that are represented there and or talked about there in those community health needs assessments. You know, they might have representation as they're having their interviews processed and stuff, but I really in particular feel strongly it's connecting them to the right folks. And a lot of them have done that throughout this pandemic, because we had I love to use our North Country hospitals. They talked with everybody in the community. They had these weekly calls because of COVID to say, listen, if COVID cases rise in the prison that's there, then the cases are going to rise in the community. If they rise in the school that's there, they're going to rise in the community. So they all realized how interconnected they were. And so they all had these calls together. So it's really, how do we encourage all of the hospitals to kind of talk that way of we all affect each other and how do we all work together better? And then, and then trying to navigate this world. I'm in the same world as well. I've had all of this meeting time because I haven't had to commute anywhere between meetings. And so how do we live in this new world of now we're going back to some in person, some virtual, and how do you still have time to have all of those meetings to prioritize those connections? So I'm not sure we're at the training stage yet. I think we're really at the, how do we connect with what's already going on? And there is some trial run of there's a platform that I'm losing the name of in my head right now, but it's essentially a closed loop referral system that was implemented for part of the time during the pandemic that will help connect organizations. They say, Joe Schmo needs this, this, and this, and then the organizations, it's called Unite Us, the Unite Us platform. So those kinds of things I think will be really helpful moving forward if we can continue that. Long answer for a short question.
No, I appreciate that. So it sounds like it's, rather than training on population health, it's more providing resources or platforms on how they can connect and collaborate.
Yeah, the you're not alone thing is really helpful, right? You're not in this alone. How do you connect to the other groups that are already doing this work or doing work in these other areas? So.
Thank you.
Yeah.
Awesome. Well, thank you, Alia, for our presentation. I will thank everyone, Lisa, as well as others who chatted their questions in, as well as Sally. I will encourage everyone to join us following the break for a facilitated group discussion, and that's really what we're hoping to have, is a group discussion focused on how to support value-based care as a state flex program. So Alia alluded to a bunch of the things that we hope to highlight and to talk about: identification of needs and who's doing what, so you have at least an idea what's going on so you can support those efforts. That will be at 2:40. The link is there in the comments section. So join us at 2:40 for that. Thank you again, Alia.
Thank you. Have a great day, everyone.